Good morning, everybody. Welcome to International Telegram Rounds. This is year 12 of this meeting. I would like to introduce you to Dr. Wellington José dos Santos, Professor of Trauma and Surgeon, Universidade Católica de Brasília, Hospital de Base de Brasília. He's going to be presenting the case with Dr. Bruna Hanauer, surgery resident Hospital de Base, and Dr. Douglas Pinheiro Cavalcanti, surgery resident Hospital das Forças Armadas. I know both of the hospitals in Brasília. In the capital of Brazil, there are two good hospitals, and really they take care of trauma. And it's a pleasure to have Dr. Wellington Santos here today again, representing his bite in Brazil. Dr. Santos, I'm looking forward for a great presentation. Thank you for being here.
Okay, thank you for the introduction. It's very important for us to present this case. It's a very severe trauma shock. I think it's because challenging case, very important. And today, our trauma surgeon will conduce this case, okay? And I permit to them to introduce themselves. And after Dr. Bruna, we begin to the case. Okay, can you introduce you, Dr. Douglas?
Okay, good morning. My name is Dr. Douglas Cavalcanti. I am surgical resident from Hospital das Forças Armadas.
Dr. Bruna.
Good morning, everyone. My name is Bruna Hanauer. I am surgical resident of Hospital de Base, do Distrito Federal.
Okay, let's begin the case. Okay, Bruna, you can begin.
In the first moment, let's talk about our hospital resource. In the emergency department, we have ultrasound, X-ray, blood gas, blood bank. Although we don't have a massive transfusion protocol, our blood bank provides bags quickly. So it's good for us. And we have angio CT too. Talking about the per-hospital care, we had a victim of car collision with report of death at the scene. The victim was 80 kilometers from Brasilia and been taken to the hospital by aeromedical service in 20 minutes. The case was passed by the team through the mystic mnemonic. The mechanism was a great destruction of the frontal region on the car. The injuries, we had excoriations on the right chest and abdomen, and no active bleeding was observed in limbs. The signals, we see tachycardia, no audible pressure, and a Glasgow 8. The treatment instituted was the administration of 1,000 milliliters of lactated ring and 1 gram of tranexamic acid. The pre-hospital team chose to intubate the victim at the scene. In the emergency department, the patient was admitted with shock. In the A, we see a patent airway. The patient was with cervical collar. We don't see subcutaneous emphysema. We see a line windpipe, and the oral tracheal tube was normal positioned. In the B, the murmur was diminished to the right without perforation in thorax, but with scoriations on the right chest. The respiratory frequency was 16 and the saturation 86. In the C, the abdomen was with scoriations. The heart rate was 135, and we don't see no blood pressure, and the pelvis was closed. In D, we see a Glasgow 8. The patient had a Glasgow 8 at the scene. On admission to the emergency room, was under sedation. The pupils was miotics, no movements in the limbs. In the E, without bleeding or fractures in the limbs. We made a blood gas in the emergency department. And in the blood gas analysis, the patient presents acidosis and increased in base excess that made us think of active bleeding, and also increase in lactate compatible with the poor tissue perfusion that we identify in patients. What we are gonna do now.
Okay, Dr. Fraga, your comments, please. We cannot hear you, Dr. Fraga. Can you?
Can you hear me?
Yes, now we can hear you.
Okay. Good morning. Very interesting, high energy trauma, and the patient is on shock at admission. So it's very important activate. You don't have a massive transfusion protocol, but you have a blood bank. So you need to start as soon as possible to give blood for these patients, red blood cells, FFP, and start the transfusion. And it's very important to identify where the bleeding is coming from. So my suggestion is to have a chest and pelvis X-ray and EFAST at the emergency department, at the emergency room, to try to identify where the bleeding is coming from. I think this is important, and activate the OR to prepare the anesthetist team, prepare to receive this patient. Probably in a few minutes, this patient needs to go to the OR. And so you need this information to continue to discuss the case. Thank you.
Thank you, Dr. Fraga. Dr. Frisby, any comments?
Yeah, I appreciate Dr. Fraga's comments. I think that's true. In the simultaneously, I think I put bilateral chest tubes in this guy just because I don't know if he's moving any air. The pressure doesn't look very high. And I'd also include, if you're going to take him down to the x-ray department or wherever you're going to get your x-rays, make sure you get his neck. But that's all I have.
Thank you, Dr. Frisby. Dr. Antrak, Iraq.
Yeah, so all good comments. I think, so assuming he has 2 IVs, and then I should probably get a 2nd gram of tranexamic acid, and then exactly where's the bleeding coming from? It sounds like he may need a chest tube on the right side, but I would do an EFAST immediately, even before you can get that done, before they can even wheel the X-ray, the portable X-ray machine, to the patient's bedside. So you need to see, does he need chest tubes? And then if he's bleeding in the abdomen, then I would just take him right to the OR, and be careful about the resuscitation. I would do damage control resuscitation, especially since you don't have massive transfusion protocol. Just get him to a systolic blood pressure of 80 or 90, and then off to the OR to control the side of the bleeding. It's going to be either the chest, and if it's in the chest, likely the right chest, or the abdomen. And I think blunt trauma like this, with such profound shock, I'm guessing that it's likely to be in the abdomen primarily, and then secondarily in the chest, but it's just a guess.
Thank you, and Dr. Ochman, Boston.
Well, this patient, you don't know why he's hypotensive. So I will go first a chest and pelvic x-ray, and very quickly or simultaneously with that, a FAST to look for intra-abdominal bleeding. In the chest x-ray, I can see a massive hemothorax or a pneumothorax, I don't know, but those are 2 potential sources of hypotension. In the pelvis, he has a pelvic fracture. I might need to alert IR to get ready. And finally, the abdomen, the ultrasound. And if I see that the patient has free fluid in the abdomen, I will take this patient to the operating room straight. Having said that, this patient only received 1 liter of Ringers. There are many papers nowadays that show that initially patients with significant intra-abdominal bleeding might not, even done by radiologists, the free fluid might be missed. And that might be missed because there is not too much. The patient doesn't have too much blood volume to bleed into the abdomen and become hypotensive to be seen in the ultrasound. So after resuscitation, this is clearly seen. I agree of keeping this patient relatively hypotensive. I would try to aim to a systolic blood pressure of 90 maximum. Having said that, I don't know if he has a head injury. A systolic blood pressure of 90 in a patient with a head injury really increased the mortality. So, and it wasn't moving. So the Glasgow was 8 on a scene. So I don't know if the Glasgow is 8 because he has a head injury or because he is hypotensive and not perfusing the brain for that reason. So it's a very, very complex case. I think we need to go with the scene that will kill the patient first. So if he has free fluid in the abdomen, I will go to the OR. I will resuscitate, if possible, to systolic blood pressure of at least 90. And if I can, and I know this will be very controversial, I will do at least a head CT because it has not been unusual for us that we have to have the neurosurgeons operate at the same time that we operate in the abdomen. We have a protocol how to position the patient in the OR for circumstances like that. That's all I have. Thank you.
Thank you, Dr. Rahman. Dr. Nedelkovic, Philadelphia.
Good morning, everyone. I agree with all the comments. I think preventing hypotension and hypoxia here in this patient with a GCS of 8 will improve his outcome if he has a severe head injury, as doctors before me discussed. I would start with blood. I'll prepare for chest tube on the right side as quickly shoot a chest X-ray and a pelvic X-ray. A lot of things should happen at the same time here. And based on the X-rays, he may buy a right chest tube or bilateral chest tubes. Also fast, and looking at the pericardium, he's bleeding until proven otherwise, and only when he's ruled out for bleeding, then we can say he's hypotensive because he has a high spine injury, or maybe he has a severe blunt cardiac injury. And also we should keep in mind that his deceleration injury 80 kilometers an hour and the passenger is dead at the scene. So I'm concerned about his aorta too. And aside from the fast and the x-rays and the blood, I would put a Foley to hopefully get an answer if the retroperitoneum is injured, the kidney, if there is any hematuria. Thank you.
Thank you, Doctor. Dr. Burke, any comments? Can you hear us, Dr. Burke? Okay, we'll go back to you, no problem. Dr. Supa, do you have any comment?
I agree with putting in the right chest tube in this patient, do the to check your blood. And I think
Can you hear me now?
Yes, we can hear you, but it's breaking, Dr. Burke.
Yeah,
maybe if you stop sharing the video, maybe we can hear your voice better. Let me stop the video.
So I didn't want to interrupt the last person. Can you hear me now?
Yes, we can hear you, doctor. It's breaking, but you can hear you.
All right, I'm very sorry about the, I'm on a different computer today. You know,
You're muted, doctor. You're muted. Okay, doctor. Okay, Dr. Burke, can you hear us now?
yeah, I'm sorry. I'm really sorry about the microphone. I would focus on his O2 SATA 86. And if you can't get, you know, an X-ray in the trauma bay, I'd put in I'd decompress his right chest first, assuming that the ET tube is in the correct position. It looks like it's okay on the chest X-ray, but I don't know if you have CO2 monitoring, but I'd want to confirm that it was positioning correctly and then go for the right chest tube to try and get that O2 SAT up. because that's right now the main concern to me.
Thank you, Dr. Burke. Dr. Supa, your comments? Thank you for your patience.
Nothing more to add. Just I think this patient needs to go quickly to the OR. Thank you very much.
Thank you, Dr. Supa. Okay, Dr. Santos, we go back to you.
Okay. Can you continue, Dr. Bruna?
Then, at the emergency room, we administered 2 packs of red blood cells for these patients. The ultrasound shows us absence of right pleural slip. Then we had a hypertensive pneumothorax. The FAST was negative, and in the 50 intercostal space on the right, we made a puncture, a needle thoracostomy, and that show us air and blood. Then we made a right thoracostomy, and we had a persistent with escape of air and a 900 blood of cell. The vital signs of this patient after these procedures was 100/65 of the pressure, and their heart rate was 110 BPM. After that, the patient was stable. Then we decided to put him in the CT, and we decided to make a all-body CT with skull, cervical, chest, abdomen, and pelvis. The skull CT shows us a small subdural hematoma and subarachnoid hemorrhage. The cervical CT shows us a fracture of odontoid process. And the chest CT shows us a subcutaneous emphysema, moderate pneumothorax, a contusion on the right, middle, lower lobe laceration, and a small hemothorax. The abdomen CT shows us a small hemopneumoperitoneum. We had a hepatic trauma, grade 4, and a splenic trauma, grade 3. Then this patient going to the emergency room, unstable. The blood pressure was 85/65, and the heart rate turns to 120 BPM, and we indicated a surgery. But in that moment, what is the recommended behavior? A laparotomy or a thoracostomy for this patient?
Just so you comment, because this patient had hepatic grade 4 injury, and spleen grade 3, but he has just a small free of liquid in abdomen, and we want to the question what we're going to do first, because we indicated the surgery. You are going to make laparotomy or thoracostomy. This is.
Thank you, doctor. Dr. Supa, your comments, please.
First, I think there is still lots of air trapped in the right chest. I will try to revise the right chest tube and make sure that the chest tube is working properly. And after I fix the chest tube and the blood pressure didn't get better, I'll try to give him some more blood. And I think he needs laparotomy to stop the bleeding in the abdomen. Thank you.
Thank you, Dr. Supa. Dr. Fraga, your comments?
Yes, we are discussing here with the residents and assistants. So we have a 900 cc of blood in the chest. In the abdomen, you have a complex injury in the liver, I cannot observe blush. I think there's no blush in the liver, correct, Wellington? No blush in the
No
liver
blush, no blush.
and the spleen.
No blush.
So, okay. But you have a large amount of blood in the chest. I think in this case, I suggest you start with right thoracotomy to try to control the bleeding from the chest. And after this, reevaluate the patient, but probably a laparotomy because the patient is unstable. This can change in the next few minutes. After giving more blood, the patient can remain stable. So you have time for the decision after the thoracotomy. But the patient is at the OR. I think it's safer open the abdomen to investigate about liver and the splenic bleeding. The splenic is very easy to treat. Just you can do a splenectomy. But in the liver, complex liver injuries is more difficult. But there are lots of surgical approach to the liver to control, having in mind damage control surgery for these patients. I think this is important. Thank you.
Thank you, Dr. Fraga. Dr. Frisby?
Well, having looked at that pictures of the neck, I probably would stabilize that immediately. He's got a certain degree of neurotrauma here to add to his bleeding. So if you decide to go in, I wouldn't move him very much. He's got a low blood pressure and a high heart rate, and obviously he's bleeding from somewhere. Either that or his vessels are all dilated from his neurotrauma. But since there's no blush, I think I probably would start with the chest. But that's my only comment.
Thank you, Doctor. Dr. Antrak, your comments, please.
Yeah, so in fact, there are really some very good comments by Dr. Hockman about the, the negative fast in the abdomen, and then the need for the CT. I think the odontoid fractures is, I'd ask the neurosurgeons, but I believe that's a stable fracture. It's a portion of the upper portion of the odontoid, but and then the intracranial injury is rather mild. There's no mass effect. So, and he's primarily hypotensive, not hypertensive from a head trauma. But as far as which cavity to open first, that would depend on the output from the chest tube. 900 cc's, that's a lot of blood coming out of the chest. There's still a significant amount there. So I'd be concerned maybe the chest tube is not functioning if the chest is not fully expanded. If need be, I put a second chest tube in and judge by the amount of bleeding from the chest tube. In the OR, I might actually position him in the right thoraco-abdominal position. So if need be, you can enter the chest quickly. If you take care of the spleen and then he's still hypotensive, then and the chest tube output is increasing, then you can go into the right side. And then I also have a question about the fast. You say it's negative, but really looking at the CT of the spleen, there should have been something abnormal. If not blood in the splenorenal fossa, there should have been an abnormal appearance to the spleen itself. You should have been able to, when you look at the spleen, you should be able to see an irregularity that is non-uniform. So maybe in Brazil, you can address that, whether in retrospect, looking at the images, whether really the parenchyma of the spleen really was normal. I would imagine you should be able to see something not right, even if not a lot of free intraperitoneal fluid. Thank you.
I made this fast, and the first time it was negative. Okay, and I think the patients arrive very, very fast in our hospital, and sometimes don't have time to have a free fluid in abdomen. I think this is the answer for this question. Okay, and after when we make the CT, show us that the patient has a free fluid in abdomen. Okay, thank you.
Yeah, yes, and that's what Dr. Hockman was saying, but also the parenchyma of the spleen itself. I would, did it look totally normal? Normally when you do a fast exam of the spleen as normal, you can see a beautiful, beautiful capsule, and the parenchyma is uniform, and you see the vessels but I would imagine in that case the parenchyma inside the spleen itself. And maybe I don't know if Dr. Hockman or the others can address that, but whether or not that should also be apparent, or you can even have a negative appearance even when the spleen is ruptured like that.
Dr. Santos, can you show us the move of the CT of the chest? Just play the move. No. Yes, the chest. Okay, thank you. Excellent.
We don't have too much blood in here, okay? We have a moderate pneumothorax and just a small or moderate hemothorax, I think. It's just this. Okay.
Dr. Santos. Dr. Hochman, your comments?
Okay, so well, my first question is this patient is still bleeding? I don't know if anything keeps coming out from the chest tube. There is not too much there. There is no blush. So I saw the spleen there in the next slide, but I would say something that it would be probably very controversial. At this time, I was trying to find out if the patient is bleeding before doing anything. And the reason for this is, yes, normally we try to keep patients with permissive hypotension when they have torso injury. Those papers were really written for penetrating torso injury, chest, abdomen, pelvis. But we can easily extrapolate that to blunt injuries. So I don't think anyone can justify bringing the blood pressure up in a patient who might be bleeding from the spleen or the liver before you have control in the OR. However, he has a head injury too, and a head injury with a blood pressure of 90, as I mentioned before, it can be very serious. I remember a paper a few years ago, an injury where they were doing a big database study, and they were proposing that 110 should be the minimal blood pressure in a patient with moderate to mild head injury. So this is a difficult situation. It's where you do if you do, and you if you do. I would first assess if the patient is bleeding. I will keep resuscitating. Is bleeding from the chest or is bleeding in the abdomen? I don't see a blush. I agree with Dr. Supa, maybe put a second chest tube to evacuate the hemothorax completely. Many of the lung injuries, when the lung expands, they stop bleeding. And the negative FAS that we were discussing before, I remember one paper, and I think I have it someplace in my computer. I can try to find it and send it to the group later, where radiologists did the FAS, and even radiologists, trained radiologists, were missing the bleeding initially because the patient needed to be resuscitated before the FAS will turn out positive. So that will explain why the FAS was negative. The other thing is, and recently, I think it was like 2 weeks ago, I also got burned because I said that when you have this type of thoraco-abdominal injuries, the liver is usually the source of bleeding, and I would have gone into the abdomen, and Dr. Supa correctly went into the chest and was bleeding from the lungs and the IVC in the intrathoracic portion. So it's a difficult decision when you have this type of right thoraco-abdominal injuries. Statistically, most likely source of bleeding will be the liver through a hole in the diaphragm, but it's very, very difficult to decide which type of incision you will do first. So that's all I have. Thank you.
Thank you, Dr. Hoffman. Dr. Nedekovic, please, your comments.
Great comments from everybody. Not much to add here. Just make sure he gets anti-seizure prophylaxis. I would put a second chest tube to take care of the pneumothorax, as maybe the first chest tube is clogged. It's still a lot of pneumothorax over there, not necessarily a lot of blood, so I'd be concerned about his right bronchus. But in terms of which cavity I would enter first, I would enter the abdomen, not because I saw the second slide with the spleen, but because he has two bleeding points in the abdomen. There was no blush, but his blood pressure was 85 to 65. So I don't know, maybe that's why there's no blush. So I would go there, take the spleen out, pack the liver. If the diaphragm is ruptured, I'll try to look through that and see what's bleeding in the chest. If not, he should be positioned in such manner that they'll be prepared to open the right chest via right thoracotomy. Thank you.
Thank you, Doctor. Dr. Santos, go back to you.
Okay. Okay, Dr. Bruna.
So
okay.
it was chosen to perform a laparotomy, and it was performed in around 30 minutes after the end of the splenectomy. It was observed the drainage of the chest tube was around 700 milliliters, and that after 45 minutes after the arrival of the patient, so the thoracotomy was indicated. In this image, we can see the operative findings. There was laceration of the middle lobe associated with bronchial lesion and active bleeding. This image on the right is when we asked for the anesthesiologist make a Valsalva maneuver, and we filled the chest cavity with saline. So we know this maneuver as manobra do borracheiro, and we observed that there's no air escape or blood escape.
Can I make just a little comment here, Cavalcanti? Why did you option to make laparotomy first? Because we have a tube in the right chest, and we are observing the thorax, and we performed the laparotomy because it was a cavity that we don't make. We don't know what we're going to find it there. And you make the laparotomy. It was very fast laparotomy, and after this, the patient had a nerve of 700 milliliters of in the right chest, and you indicated thoracotomy that show us right now. Okay, continues, Dr. Cavalcanti. Okay, you said about it.
Dr. Santos, just a question. How about the liver? Is there bleeding coming from the liver? No. Did you pack the liver or no? No bleeding coming from the liver?
There wasn't no bleeding coming from the liver. The liver, it was just in parenchymal. Okay. There was a bleeding coming from the spleen, but there wasn't a bleeding from the liver. Okay.
Okay, no active bleeding. Okay, thank you.
Okay, bleeding, just this.
So after the surgery, it was put an anterior and a posterior thorax tube, chest tube, and the patient was referred to the intensive care unit to maintain neuroprotection measures and only with prophylactic antibiotics.
Just for information that you don't have here, I don't put here, the patient received 4 packs for red blood cells and PPF, and it's all okay.
Okay. On the 4th postoperative day, the patient started with fever and worsening of his breathing pattern, and it was ordered laboratory tests, cultures, and chest X-ray. On the results of these exams, it was diagnosed as pneumonia and leukocytosis. The patient presented leukocytosis and high rise on the C-reactive protein. And by the protocol of our hospital, it was chosen to start ampicillin and sulbactam. And on the 10th postoperative day, the patient started with constant fever and again with worsening of the breathing pattern. The culture of the tracheal secretion was Pseudomonas aeruginosa, Klebsiella pneumoniae, and Proteus, and it was staged the antibiotics to meropenem, vancomycin, and gentamicin. The antibiotics were staged and there was no improvement on the clinical picture, and the patient presented a difficulty in adapting to mechanical ventilation and considerable worsening in the laboratory. It was opted to perform imaging exams, and here we ask, what is the hypothesis of this patient? Has it a subphrenic abscess due to the splenectomy, or is he presenting a pneumonia complication? What do you think?
Okay.
Okay,
So-
we'll,
Just a few. This is CT. After the CT, I want you to make the question. Okay.
Okay. On the abdomen CT, we see an organization of the liver trauma and only a small amount of free fluid in the cavity. On the chest CT, we see bilateral pneumonia with intraparenchymal air fluid level on the right lung base with a small pleural component.
And we make here the diagnosis of abscess, intraparenchymal abscess. And continues, Cavalcanti.
Okay. So what's the strategy to follow with this patient now? Thoracoscopy to drain the abscess, thoracotomy to drain the abscess, drainage by interventional radiology, or just follow up the patient with expectant measures?
The problem that we have here now is a patient that has an abscess in the pulmon, but we made a bronchial suture, okay, and this is what we're going to the question, what we're going to do to this patient's now, okay.
thank you, Dr. Santos. Dr. Nedeljkovic, your comments, please.
Could you please tell me what post-op day is this? 6?
What? Understand?
How many days out of the surgery is the patient at this time?
Okay, it's here. It's in the 50 days. 50 days.
Okay.
50 days.
So I think what I would do, I would reach out to IR. I would have them maybe instill TPA in the right chest to the chest tube to see if we can break some of that, loculation and repeat imaging. And I would also ask them to sample the liver for, liver abscess rule out. Thank you.
Dr. Antrak, Iraq?
Yeah, so early on when the patient appeared to have pneumonia, I would consider bronchoscopy, and then you can see, is there pus coming from, where is it coming from? And it looks like in the lower lobe in this case, based on the CT scan, the air fluid levels seem to be in the lower lobe. As far as the subphrenic abscess hypothesis, I assume you had a drain in place that was not draining. I wouldn't expect an abscess. It was 4th day when he destabilized. That, and also depending on how he was doing on the ventilator, if he was if he was able to wean or not wean, you know, then that would suggest it's more coming from the obvious abscesses in the lower lobe. And then also in the CT scan, it looked like the gallbladder was a bit thick-walled. There was fluid around the gallbladder, which might have just been post-operative changes from the hemoperitoneum. And I assumed that the radiologist looked at it and wasn't too concerned, but it didn't look normal on the images you showed. And I'm assuming that that's just a red herring. But I think the problem is in the lung, and I would tend to be more aggressive if he's getting worse and his white count is going up. I would do a bronch, see if there's pus where it's coming from, whether you can open up the airways that way and get some drainage. And then if there was still a question, I would be inclined to be more aggressive and enter the chest again, look at the infected lung, see if you can save it. And if he's just not getting better, then the abscess were confined to one area, I would try to drain it through a thoracotomy incision, or if need be, you do at least a partial resection of the infected tissue.
Thank you, Dr. Antrak. Dr. Hochman, Boston.
So a few comments. First, when I was looking at the surgical repair, one thing that we always need to be worried when we are repairing a lung like this is air embolism. Sometimes patients crash when we're trying to do this, and it's because of air embolism. So, and the positive pressure ventilation getting into the pulmonary veins is what will cause the problem. So we need to be mindful of that. Second, the injury that again, this is difficult looking at the video, was very close to the hilum, or at least to the beginning of the bronchial lobe. So when you were presenting this, the first thing I thought was a lung abscess secondary to Pseudomonas. Pseudomonas and Staphylococcus tend to cause lung abscesses. So that would have been my first thought. If I have a patient like this with progressively raising white count and that chest X-ray, that would be my first concern. I will do a CT. I would have done a whole body CT like you did, because sometimes we get surprised. I agree with Dr. Untrach. The gallbladder looks funny. So he's at risk of developing cholecystitis, a calculous cholecystitis maybe. But the main issue that you have here are the abscesses in the lung. So it would be coverage with antibiotics and probably IR drainage, because it's the easiest thing to do. I will be concerned from this patient because he has sutures there developing a bronchopleural fistula. That might be a problem. The other possibility, and Dr. Untrach mentioned also doing a bronchoscopy, that is a narrowing into the main airway that resulted in accumulation of infected secretions distally. And in that case, it's unlikely that any of these measures will work, and this patient will need a resection of that lobe. But this is too early to say that, but those things that I will keep in the back of my mind. Thank you.
Thank you, Doctor. Dr. Frisby, any comments?
Yeah, I appreciate what Dr. Untrach and Hoyman have said. It's been 10 days post-op, and now you've got this organized issue in the lung. You can turn it over to IR if you want to. It's been my experience that they don't have tube big enough to suck all that out. It's too organized by now, and you're just going to have to decorticate that if you want to. I'll be really careful. You've got some sutures in there, but I don't think you're going to be successful. Although, like I said, I have limited experience with IR, but after 10 days, it's very, very possible that this stuff is very fibrinous and it's not going to, IR is not going to be very successful. That's just my comment about the lungs. As far as the gallbladder, hey, that's fine. We'll do it later. That's all I've got.
Thank you, Doctor. Dr. Supa, your comments, please.
I think that the lung abscess that he has may be secondary from obstructed pneumonia. That is probably caused by operative injury of the right lower lobe bronchus, maybe by suturing to close it. And eventually, if he has obstructed bronchus, the infection will not be able to clear out spontaneously, and he will end up needing thoracotomy and lung resection to clear this infection. I agree with doing bronchoscopy to check whether or not the bronchus is obstructed, and try to drain the pus out from the bronchus. If the bronchus is obstructed, the patient will need other type of drainage. I think IR is possible. It's less invasive, and now it's 15 day 15. It would be quite difficult to redo thoracotomy at this time. I think IR drainage may buy us some time to make him better and make him ready for the second operation to go in and resect the infected lung. Thank you very much.
Dr. Supa, Dr. Fraga, your comments, please.
You agree, the patient is septic or only has fever, Dr. Santos. How is the patient at this moment, 15 days after the surgery? Is the patient septic?
No, he wasn't septic.
No.
But the leukocyte was getting high, and the protein C reactive is very high, and the patient he had difficulty to adapt it to the mechanical ventilatory. Okay, and it's this the what it was happening with him.
And how about the ventilation at this time? Is the patient?
It wasn't very good. He needs,
only with oxygen?
No, he was intubated, and he needs a high pressure, high PEEP, and the ventilation perfusion is not very good. Okay.
Okay. So you agree to start with the bronchoscopy, just to clean, to look in the lung, because there's an image of abscess. There is some pleural effusion too, but the chest tube is on the pleural effusion. So probably the liquid is coming out by the chest tube. So start with a bronchoscopy. After the bronchoscopy, discuss the case with a thoracic surgeon. Usually they have more experience to treat this case. It's a complication, but it's a difficult case. And I think the bronchoscopy check the antibiotics is important at this time. Thank you.
Thank you, Dr. Fraga. Dr. Santos, we go back to you.
Okay, I will continue the case right now. Okay, we talk about our thoracic group that they don't indicate thoracoscopy because by the risk of formation of a bronchial fistula in presence of infection, they said if this fistula could happen, is very difficult to maneuver this to take it out this fistula. Okay, because we make a literature, and they show that this fistula has a high mortality for 35 to 71%. And we talk about to make a bronchoscopy, and they didn't indicate at that time because we have some abscess and the possibility to open this bronchofistula to the trachea, and we talk about to make interventional radiology procedure, and it's what we done. We make interventional radiology procedure we make the drainage from abscess. Okay, it's here and show a drain that can evacuate approximately 150 milliliters of a secretion like a pus. Okay, and after this, the patients get better. Okay, the fever go down, drop the local stores and C reactive protein. He had decrease in ventilatory parameters and being materialized by trauma team surgery. We are follow up how he is in the ward right now. He's out of the ventilation and he is in rehabilitation, and we are proposing to perform a resonance imaging to cervical spine into evaluation of a neurosurgical intervention. Okay, this is the trauma index that we calculate to him. This patient have probabilities of survival in 17.23%. Show us that this is a very critical patient. And if you don't have a trauma team, if you don't have intensive care, if you don't have a pre-hospital team, all of us are working together, we don't have this result. Okay, and the conclusion, I think this thematic, when you have a trauma team, is important to follow in the challenge case, and transforming unstable patient to stable patients provides a possibility to make a strategic surgery. This patient arrived for us very, very, very stable, and we turn him stable in the emergency room, take blood cells, okay, and this make the possibility to make a CT for this patient. And I think it's very important to this patient, you have a CT, okay, because will show us what you have here, the possibility of a strategy, of a surgical strategy. And that's all, and thank you for all.
Thank you, Dr. Santos. We'll go to final comments briefly. Dr. Fraga, any final comments?
Congratulations, Dr. Santos and the team in Brasilia. You know, in Brazil, we're trying to organize the trauma system. And Brasilia is the capital of the country. And they have a good team there, a lot of young surgeons dedicated to the trauma. And it's very important. They have a residence on trauma surgery in the last 5-6 years, maybe. And it's very important to organize the system with the pre-hospital and the hospital dedicated to trauma patients. So congratulations, it's a difficult case, very complex the case, and the patient survived because you did an excellent job. Congratulations.
Thank you, Dr. Fraga. Dr. Supa, any final comments?
Thank you very much, Dr. Santos and the team for presenting this case to us. We learned a lot as usual, and congratulations for the great outcome you have for this patient.
Thank you, Dr. Supa. Dr. Frisby, any comments?
Every time I come to one of these, I learn something. So this was a very, very good experience for me. It's just great. Congratulations, you did great. Thank you so much.
Thank you, Dr. Frisby.
Dr. Ochman, any comment?
No, I want to congratulate the presenters for this patient, as you mentioned at the end, had a very high mortality, and you managed to steer the ship safe to port, and that's really very, very good. I just, when we were talking, I just did the search and I sent to the group this article of the ultrasound performed by radiologists, and that why initially cannot exclude intra-abdominal trauma. But anyway, so I hope that this is helpful. I agree with Dr. Frisby. Every time I come here, I always learn something new. Sometimes I am, it's really painful to realize how little I know, and I thank all the people commenting and the presenters for this opportunity. Thank you.
Thank you, Dr. Antrak. Any final comments? We cannot hear you, Dr. Antrak. You're muted.
Sorry. Excellent case, particularly because of all the complications, and learned an awful lot. Some of the lessons that were already mentioned by the presenters, you know, if you do an evaluation, doesn't seem to make sense, or something's not going right, or the patient takes a downturn, start at the top and evaluate again. If the FAST is initially negative and it looks like it should be positive, you know, do a bit of fluid resuscitation, and then check again. And then in this case, probably it certainly would have been positive later on. And the management of the abscess was masterful. I think that was good that you got the thoracic surgeons involved. And in this case, it looked like maybe it was a multifocal, multilocular abscess, but a single drainage catheter was enough to turn things around. So that was very, very well handled. And it's just, you know, these just wonderful conferences to really learn from the experts, and it's very enjoyable. And thanks for presenting such a good case.
Dr. Nedelkovic, any final comments?
Great case. Thank you for presenting it. You know, we're happy. We have a great IR team here at our hospital, and you know, always very helpful. As one of my colleagues, to quote one of my colleagues, he said, "It would be crazy not to go in surgery nowadays with such great IR backup." So thank you for presenting this case. I always learn something when I attend this conference. With regards to the FAST, I think in my experience, it's negative sometimes because the patient's hypotensive and is not bleeding, but it will come. And also when the blood clots right away, it may masquerade how your waves from the ultrasound are absorbed. So maybe you know, false negative. Thanks, everyone.
Doctor, I'm not sure if Dr. Burke, can you hear us? You have any comments? He's having a problem with his mic. Yeah, thank you very much, Dr. Santos and team. We hope to see you again soon. And next week,
just a few comments. Okay,
oh, sure.
I am to say to Dr. Bruna and Dr. Douglas, thank you for preparing this case for us. Okay, and I'm going to say to Dr. Fraga, I'm very happy to see this auditorium with your student, with your resident, with your surgeon assistant. It's very beautiful to see all of us in this morning to discuss trauma. We are very happy, and this is the imagine that I can stay very, very happy to see Dr. Fraga. Congratulations to your team, congratulations to Unicamp. We think to see all of this person, all of these people doing this, it's very important for us. Is think like this that make us believe that the trauma surgery will grow in Brazil. Thank you.